Our next speaker is Afidan, MD, MPH. Dr. Afidan is a professor of neurology at UCLA, where he serves as the director of the Sleep Disorders Center and director of the UCLA Neurology Clinic. Dr. Afidan previously served as visiting professor of neurology education in the Department of Neurology at the Mayo Clinic College of Medicine. He is a fellow of the American Academy of Neurology and the American Academy of Sleep Medicine. Dr. Afidan received the Super Doctor's Distinction in 2013, which is given only to the top 5% of physicians in that state. So looks like we're getting things set up here. It'll be just a moment. And then Dr. Afidan will start his presentation.
Thank you so much.
Thank you.
That's what happens when you use a Mac. The sound. This is all the way up. And then what we'll do is I think this should work. The sound is all the way up. So they should be. I'm just going to play one video clip real quick just to make sure that we have good sound. Okay, good. Very good. So you might have imagined this talk is about sleep. And this is a perfect time because I get to talk to everyone right after you have lunch, and this is 2 o'clock, and your circadian rhythms are just firing up to fall asleep and take a siesta, but that's perfect. That's okay. If you want to take a nap, this is the perfect time to do it. I won't get offended. So we're going to talk a little bit about sleep disorders and their relationship to neuropathy. I want to just give you a brief outline that sleep disorders, untreated sleep disorders, often confer a high risk for pain threshold, depression, restless leg syndrome, or Willis-Ekman disease. And very interesting, restless leg syndrome is often associated with very painful peripheral neuropathy and often confused with neuropathy. Poor sleep also leads to poor quality of life. We're then going to go into some of the unique sleep disorders that may have comorbidities with neuropathy: obstructive sleep apnea syndrome, insomnia, narcolepsy, circadian rhythm disorders, restless leg syndrome or Willis-Ekman disease, and REM sleep behavior disorder. Why do we sleep? You know, I threw a few slides about why is sleep so important, because I often get asked this question as a sleep doc. Why do we sleep? Why is sleep so critical? And a few years ago, I used to say, well, there are about 13 theories about why you sleep, and it's time for neuronal repair and memory consolidation. But really, I had to work extra hard to convince people that those theories are actually true. As of about 2 years ago, there's a new theory based on the glymphatic system, which is essentially the brain's lymphatic system, which essentially clears up toxins and garbage from the brain, proteins, abnormal precipitates of metabolism, and this function happens exclusively during sleep. Only during sleep. So as you can imagine, patients who are not getting enough sleep are not getting those proteinaceous toxins and garbage cleared as effectively as patients who are getting a good night's sleep. And in fact, in laboratory animals who were sleep deprived, those animals developed more precipitation in the cerebrospinal fluid of beta amyloids. And beta amyloid is a precursor for Alzheimer's dementia. So can we imagine that poor sleep, disrupted sleep, is the same type of risk factor for sleep deprivation and precipitation of beta amyloid in humans? That really remains to be shown, but it opens the realm to really be able to assess this for the sleep disorders, treat them effectively, and always try to fix the insomnia, because we in sleep medicine often don't accept the fact that the patient sleeps poorly. We really need to go after the causes and treat the disorder. Unfortunately, a lot of patients are still accepting the fact that they have a poor quality sleep, and they're resorting to the fact that they're going to just nap during the day or on the weekends. But that's really something that can be improved if you go after the right diagnosis and you take a good clinical history. That the treatment is quite effective. So let me go into additional data. We know that, for example, the data shows also that older patients have more problems with sleep disorders, and neuropathy as an entity is more frequent as we grow older by virtue of the increased comorbidities like diabetic neuropathy. And the fastest growing segment of the US population are those patients of age 65 and older. So it's really incumbent upon everyone in the field, patients, to really be able to go and really screen for the sleep disorders and treat them. All right, so this is just one theory about chronic consequences of sleep deprivation. And I want to just give you one anecdote, which is napping. Napping is actually good for you if it's strategic, number one, and number two, if it's short. So when people ask me about napping because they're tired, the best time to do it is just between 1 to 3 p.m., just around now. For about 15 or 20 minutes, and those are very effective power naps. The problem is that patients are often taking the naps too early during the day or too late during the day. If you take the nap too late during the day, of course, that's going to impact how well you're going to fall asleep, because if you're not having the sleep homeostasis drive, you're not going to feel sleepy when you go to bed, and you're going to have insomnia. So 1 to 3 p.m., 15 to 20 minutes, set an alarm, and that should work out. If you nap for longer than 20 minutes, you're more likely to go into slow wave sleep, and waking up from deep sleep, you're going to feel more groggy. And that's the problem. If you take a 1 hour, 2 hour naps, I'm sure you all had experimented with that, and that is worse than not taking a nap at all. So make sure it's short and make sure it's strategic. And the other thing is make sure it's in a quiet room that's protected from too much noise. Some do's and don'ts about sleep hygiene. This is also very important. My patients tell me that before they go to bed, they watch TV and then they go to bed and they use the iPad, they read, they look at the news, and then they try to fall asleep and they can't. Well, the light exposure from all these light resources and the electronics, the computer screen, the television, delays the secretion of melatonin, number one, and number two, it keeps people occupied, keep them active, and the light exposure is essentially keeping our circadian clock more active. So light pollution, electronics pollution, the worst thing you can imagine in the setting of insomnia. So we usually give patients a rule of thumb to protect the bedroom environment from artificial light for about 2 to 3 hours before going to bed. Not eating heavily, not exercising vigorously before going to bed, removing the electronics, taking a warm bath or about 2 hours before sleeping is effective, because what happens is that it drops the core body temperature, which is a good stimulus for melatonin secretion. And melatonin, of course, is needed to initiate sleep. Relaxation techniques, skipping a good sleep routine, going to bed at the same time, waking up at the same time. And of course, that's something we always recommend to our residents in a hospital, to make sure that before they take a night on call, that they're not showing up to the hospital sleep deprived. That's the number one cause of severe sleepiness while performing duties as a resident. All right, now let me go into some of the, an example of some poor sleep hygiene. So as you can imagine, these patients are not doing the right thing before going to bed. She has this is amazing. I took this from the Sky Mile magazine, or Sky Mile. I think they're out of business, which is a good thing, because they sold all kinds of unusual things, like a staircase for the dog to go up to the bed, and it was just mind-boggling. But this lady, she has this iPad contraction that is connected to her bedstand. Now, why would you work on your iPad and have a laptop connected to your nightstand? It's just, I tore this off from the magazine. As a sleep doc, I think this is my responsibility. And you notice the lady on the left, she has the clock, she has too much light, and she had Jack Daniels behind the clock. That's a really poor, alcohol is terrible for your sleep architecture. It destroys the sleep architecture, it disrupts REM sleep, and of course it has the issue of dependence and a worsening of sleep apnea. Yet, we know that about a third of patients use alcohol to help them fall asleep. All right. The one thing I wanted to tell you is that older folks, 2/3 of patients over age 65 report difficulties with waking up unrefreshed, sleep maintenance difficulties, snoring, pauses in breathing, unpleasant feeling in their legs. Again, the issue of neuropathic pain, restless leg syndrome that is often disrupting their ability to fall asleep. And again, I want to carry the point here that sleep disorders are common, they're serious, they're treatable. Unfortunately, they're often undiagnosable or undiagnosed. And the reason why is that a lot of physicians in the US, on the average, get about 1 to 2 hours of sleep education in medical school, which is not enough to really take care of patients. And we spend a third of our lives sleeping, so there has to be more education, certainly at the medical school level. I want to approach the sleep disruption as coming from external or being related to external as well as internal or patient-related factors. The external factors include decreased light exposure, especially in nursing home environment, or excessive noise or excessive light, such as in a teenager's room at 2 a.m. when they are using Facebook, and the room now becomes a kind of not a bedroom, but kind of a social media type environment. And you go to Starbucks at 10 p.m., people are ordering grande, and this is just amazing. Again, a very important cause of external factors that disrupt sleep. The internal or patient-related factors include pain, primary underlying medical problems, sleep apnea that always tend to correlate with increased age, and of course, age-related changes in sleep architecture. The aging process itself, with the degeneration of the suprachiasmatic nucleus, which is our circadian rhythm regulator, and reduced production of melatonin, all factors that can disrupt circadian rhythmicity. Unfortunately, I like to use the iceberg effect in that the sleep problems that we often see really represent the minority, and there is all this opportunity below the surface of the water of undiagnosed sleep problems that often get misdiagnosed or diagnosed as something else. All right, let's begin with obstructive sleep apnea syndrome. Sleep apnea, when untreated, can be an independent risk factor for stroke, for diabetes, for cardiovascular heart disease, high blood pressure, increased risk for motor vehicle accidents, and we now understand that this is part of the metabolic syndrome. Untreated sleep apnea can increase the levels of ghrelin. Ghrelin is a neurohormone that can cause increased appetite. The patient eats more, and the cycle begins to really take off, because with increased weight, increased BMI, the patient is going to have worse sleep apnea that could disrupt the sleep architecture even further. And here's a typical patient with sleep apnea. If we can just increase the volume, thank you. And what you can appreciate here is the patient has airflow monitoring, abdominal and chest monitoring during a sleep study. And this is an example of an apnea. So right now, he's not breathing. This is a period of apnea, and apnea is a cessation of airflow for a period of 10 seconds or longer. And hopefully he's going to start breathing again. And you can see paradoxical breathing in the chest and the abdomen. They're not working in a rhythm. And that's an increased work of breathing. And here he is. Now he took a resuscitative breath. And these patients have apneas like this 50 times an hour. You know, and you look at them and you see that the sleep is severely disrupted, the oxygen is lowered, the oxygen level goes from 90 to 75%. They wake up feeling exhausted. When we put them on CPAP, on the treatment for sleep apnea, continuous positive airway pressure, patients often come to me and say, wow, I never knew that I could dream and I could have such a good night's sleep. We're going to go into that in a little bit more detail. Let me show you, let me move on, just to show you, the number one cause of sleep apnea in a child is usually related to increased tonsils. That's exactly right, tonsils and adenoids. And children don't often present with daytime sleepiness. They present with ADD, attention hyperactivity disorder, hyperactivity spectrum, and often result in reduction of IQ even. All right, so this is why sleep apnea is not going away. You know, I was in India, 10 years ago when I visited India. At the lobby in the hotel, I remember seeing a box for donation for the research of leprosy. Leprosy then was the number one cause of peripheral neuropathy, peripheral neuropathy. 10 years later, more recently, when I visited Mumbai, I noticed that there is more problem with diabetes. Patients are, the large cities are becoming more westernized. There are now McDonald's all over. People are having increased body mass index. There is a high prevalence of peripheral neuropathy, not due to leprosy, but due to diabetic neuropathy. And with that comes the issue of obstructive sleep apnea. And unfortunately, in Mumbai, a population of 9 million, there are 3 sleep physicians who are certified to read sleep studies and take care of patients with sleep apnea. So certainly this is a shifting in the epidemics of obesity, neuropathy, diabetic neuropathy, virtually due to our influence with McDonald's and a Western diet. And take a look just in the United States from 1986 to 2009, we're showing you states with a body mass index greater than 30 kilograms per meter square. And you can see that certainly this is a growing epidemic, and you can see Alabama, West Virginia, Mississippi, the southern states are with the highest prevalence of BMI. The neurology or the anatomy of sleep apnea is related to obstruction of the upper airways at the level of the pharynx. And we have a classification system, so a doctor who looks at the throat can judge if the patient could be at high risk of sleep apnea, certainly when they have increased risk of upper airway closure using the Mallampati system. The treatment for sleep apnea, if the sleep apnea is very mild or if the patient has snoring that's exclusively on their back, we sometimes use positional therapy, using some tennis balls sewn in the back of the pajama. That helps for some patients, but you can't always predict that the patient will not sleep on their tennis balls because people rotate, and I see these patients in clinic and they start complaining of low back pain. So it has its pros and cons, but certainly very, very advantageous in people who are not candidates for CPAP, for example. Now, nasal CPAP is the gold standard of therapy for obstructive sleep apnea syndrome, and what you see is a pressure generator that's connected to a tube over a mask that fits over the patient's, say, nose and mouth, or just the nose. And what you're doing is you're splitting the airways open. The problem is a lot of patients don't like it. It makes them look a little claustrophobic. They tell me they look like Darth Vader. And I tell them, don't, you have to look at yourself as an F-15 fighter pilot and get, you get the families involved. And that's the greatest influence, is to really help the patient struggle through with their CPAP, is to get the family involved, the bed partner involved. The paradox of obstructive sleep apnea is that the patient may not realize how loud they're snoring and how disruptive their sleep is to the bed partner. And the bed partner is usually the one who is coming into the clinic with the patient because their sleep is so disrupted. So when you're treating sleep apnea, you're treating two people, which is really rewarding. And for patients who can't tolerate the typical nasal mask, there are just nasal pillows that just go over the nose, and they're not as intrusive. They're looking a little bit more acceptable to the patient, and they allow the patient to move more freely in bed. All right, so for patients who have a milder degree snoring or mild obstructive sleep apnea, mandibular repositioning devices can be also helpful, and they are very easy to carry around, and especially for people who fly a lot. All right, let's talk about insomnia. Insomnia can be divided into sleep initiation insomnia, difficulties falling asleep, difficulties maintaining sleep, or terminal insomnia, early morning awakening. I never tell my patients they have terminal insomnia, even though it's a correct term. But terminal, early morning awakening, is depression until proven otherwise. Difficulties initiating sleep is often related in the setting of anxiety, painful peripheral neuropathy, comorbid with restless leg syndrome, and also medications, caffeine in particular. Difficulties maintaining sleep is often related to untreated sleep apnea, nocturia, prostate issues, obstructive sleep apnea, poor sleep environment, those folks who live by LAX with the noise certainly can impact the sleep continuity. All right, just to show you, insomnia is often thought to represent a disorder of hyperarousal, and hyperarousal is essentially the issue where the patient is in bed and they're ruminating. They're beginning to think about the previous day, what they need to do the next day, projects they haven't gotten to, paying bills, listening to CNN, and of course this is ruminating the patient's mind, and they can't shut it off. They tell me, I wish I could find the on-off switch, right? And that's what we're talking about when we're talking about the insomnia phenotype. As I mentioned, the problem where alcohol is used as a hypnotic in about a third of patients who have chronic insomnia. What's the problem with alcohol is, it's very enticing, right? It's very enticing for patients to use it, but there's a problem. What happens when you fall asleep? When you fall asleep, you stop drinking, and that's the problem. As you can see in this sleep diary, this is a patient who went to bed at 7:45, fell asleep at 9:45, woke up at 11, had scotch, fell asleep at 11:30, woke up at 4 a.m., had another scotch. He crossed it out, but I think he had it. And then fell asleep at 4:15, woke up at 5:24, had another scotch, and woke up again at 8 a.m. So alcohol disrupts your sleep architecture. It essentially reduces REM sleep altogether, rapid eye movement sleep, dream sleep. It's often likely to induce dependence, rebound, and it destroys the sleep architecture. So always something to avoid. So another 23% use over-the-counter drugs and herbal remedies, ranging from valerian to melatonin to tryptophan. None of those really have proven efficacy, and the trials on melatonin are somewhat equivocal. In some studies, especially in older Alzheimer's patients at high doses, there is some data showing perhaps some efficacy, but studies repeating the same experiments have failed to show similar effects. Here are the, in blue are the drugs that are FDA approved for insomnia, with the most recent approved agent, suvorexant or Belsamar, which is a hypocretin orexin antagonist. And what this drug does, it's really interesting. It targets the area in the brain that is involved in arousal. The hypocretin secreting cells in the hypothalamus. This area is often implicated in patients with narcolepsy. They don't produce enough hypocretin, or they have hypocretin deficiency. So what you're doing here is you have an insomnia patient and you're inducing a narcolepsy-like state to help them fall asleep. And the data shows that, in fact, there is good efficacy, with the potential that the patient may wake up and they'll be paralyzed, for example, in the morning, or they may have narcolepsy-like symptoms. Let's talk briefly on things that can help and be alerting during the day and helpful at night. So sleep aids. You know, I never knew that cherry juice is actually helpful. It has melatonin at pretty good quantities and is soporific. Soporific means it helps you fall asleep. Chamomile tea. Just the warmth of the tea the warmth of the tea is very soothing for a lot of patients. Milk has tryptophan, which is a precursor of melatonin. Alerting agents, if you do feel sleepy or if you had sleep deprivation, caffeine can be used on demand. Make sure, though, that you're not using the coffee or the caffeine after about noontime, because then it can be much more likely to disrupt sleep. Just to show you a few examples of how much coffee there is. You know, I see some of you are having an iced tea or coffee. So 1 cup of coffee, 27 milligrams. That's about also how much you would get from shot of espresso has 27. Brewed coffee has 95 milligrams. Now, if you went down the street and had a grande Starbucks, 330 milligrams. 330 milligrams, and if you take that cup of coffee at 5 p.m., at around 6 a.m. the next day, your blood caffeine level is about 80. That's like having a can of Red Bull already on board in your blood. So if you don't have insomnia, if you don't have problems with sleep, I'm not going to have a problem with anyone taking caffeine or using caffeine. But I know people who drink coffee before going to bed and they sleep even better. I don't know how to explain it. But if you're having insomnia or any problems falling asleep, even though you're only having coffee at 10 or 11, just think about perhaps discontinuing and seeing how it impacts you. And remember, decaf also has a little bit of caffeine. You know, I went to 7-Eleven the other day. I asked for water. You know, I looked at the bottle of water, and I saw on the back that it has caffeine. You know, it's pretty amazing, and it doesn't have to be dark to have caffeine. And it's pretty, why? Or, you know, I'm not sure, you know, the beans they use, let's say at Starbucks, I think that the pigment of the coffee bean, the one that has a higher level of caffeine is from a brand that's not dark. So just briefly, you know, hypnotics it's a very confusing topic. I took this outside of Cleveland, and I heard that this was a very confusing sign to a lot of drivers. And you know, there is I see a lot of patients who come in and they tell me that their family physicians are not, you know, they don't really approve of having the patient take a hypnotic medication. And yet I see patients who are using a hypnotic agent. They're using a combination of 2, and I watch how they do. And they're thinking that using something for sleep is the first time that they were able to fall asleep, maintain sleep, and get good quality sleep. The threshold is how the patient feels the next day. If the patient is alert, awake, they're not too sleepy, they're not too tired, the medication has helped them fall asleep, they're not developing side effects, then I would argue that those patients should deserve the medication, and those questions about falls, hip fractures are something that often haven't been tested with enough validity to adjust for comorbidities and covariates. Briefly, maybe 2 or 3 minutes on narcolepsy. Narcolepsy is a disorder of severe excessive daytime sleepiness. I see a lot of patients who come in and they're convinced they have narcolepsy, and yet we often see that they're only sleeping 4 or 5 hours, right? So sleep deprivation, especially in college students. And the other thing that they have are REM intrusion phenomena, so sleep paralysis, cataplexy. I'm going to show you an example. So here is an example of cataplexy in a dog. He gets excited, he runs, and he loses muscle tone, okay? And he's still awake. But, you know, this is how you induce dogs, cataplexy in dogs. You show them food. And this is canine narcolepsy. Now, to show you human narcolepsy, this is a patient with narcolepsy, and she's trying to make him laugh, and you know he's developing unbuckling of the knees, and he has he falls to the ground, but he can anticipate this. It's not like what you see in seizure patients or patients with fainting spells. And just the anticipation of hitting a ball is enough to precipitate cataplexy. For all practical purposes, patients who have cataplexy have narcolepsy until proven otherwise. And we do see patients who read on the internet about cataplexy and they're convinced they have cataplexy. And oftentimes we find that it is indeed true, but sometimes it's often related to migraine headaches or atonic seizures. Just to show you a few more examples. So this was a vasovagal syncope, but look at the recovery.
That is correct.
So excellent recovery here. This is vasovagal syncope. This is cataplexy. Again, this is a cataplexy phases. It's a phenotype. It's the expression of the patient who watches a funny cartoon and loses the muscle tone. He has complete ptosis, facial weakness in response to the cartoons. This is cataplexy in a patient with narcolepsy and cataplexy. There are other conditions, sleep-related hallucinations, where the patient imagines things that are not there, visual hallucinations typically.
I see a huge python or boa constrictor wrapping itself. I feel it wrapping itself around my body. I can feel the pressure of it squeezing my body. And then it's, even though my eyes are not open in the hallucination, I see it looking at me. And it doesn't have snake eyes, it has human eyes.
You know, I listened to her, I could not fall asleep that night. So this is a terrifying hypnagogic hallucination. All right, briefly, by the way, how much more time do I have? 7 minutes. In the next 7 minutes, let me show you restless leg syndrome. Okay, because this is really important. So, restless leg syndrome is otherwise known as Willis-Ekbom disease. And I like the term Willis-Ekbom disease for the following reason. If the patient comes and tells me that they have restlessness, it does, or if they don't have restlessness, it doesn't mean they don't have restless leg syndrome. There has to be an urge. There has to be an urge to move. That's the criteria by which we diagnose RLS. If they don't have an urge, they probably don't have restless leg syndrome. The other thing is there is a notion that only the legs are involved. And in fact, we do find patients who have restlessness in the abdomen, in the hands, in the thorax, so it doesn't always involve the legs. And it's no longer a syndrome. We now understand that it is a disease with defined genetic markers. Here's a patient with peripheral neuropathy, painful peripheral neuropathy, pain, an urge to move the legs, and the only thing that really helped this gentleman get rid of his sensation was taking a baseball bat and hitting his legs. So you can see how disruptive this condition is for the patient's quality of life. And of course, there are now 4 FDA-approved agents specific for restless leg syndrome. But I just want to remind you, you can use the urge mnemonic. U stands for the urge to move the limbs. R, rest or inactivity, usually precipitates or worsens the symptoms. G, getting up and moving, usually relieves the sensation. And E is eveningness. There is a circadian predilection for the movement, the pain, and the urge to occur during the night. It's a 24-hour problem, but it often presents itself with more predilection and more severity in the evening time. I want to show you one other patient who, and by the way, to differentiate restless leg syndrome from other conditions, you can see peripheral neuropathy here. Peripheral neuropathy patients may have an urge, they may have restlessness, but they don't have the circadian pattern that patients with restless leg syndrome have. The two conditions overlap, but RLS, if you're concerned about restless leg syndrome, it has to be much worse in the evening time. Claudication refers to pain and an urge to move or restlessness that's usually triggered with movement when the patient starts moving, and it gets better with rest, and this is often related to peripheral vascular disease. Now, nocturnal leg cramps often get confused because it also happens at night, and it also affects the legs, but here the patients have a cramp. It's a painful cramp, it's a Charlie horse, but it's different than restless leg syndrome. It's not an urge, and it's localized specific to the back of the leg, the gastrocnemius. Unfortunately, the only thing that works for nocturnal leg cramps are exercise routines. All other medications, quinine, calcium channel blockers, have not been shown to be terribly effective. And by the way, akathisias, that's in a setting of patients using antipsychotic agents, doesn't have a circadian pattern and is often described as an inner body restlessness. Just to show you one thing about one of my patients with restless leg syndrome, we brought him to the sleep lab just to document his study for sleep apnea because he was snoring. But you can see the type of vigor and how uncomfortable his sensations were. Unfortunately, this patient did not have his restless leg syndrome diagnosed until he came to see us, and his primary physician heard that he was having problems falling asleep and there was an issue with the legs, so the physician put him on Ambien, put him on a hypnotic medication, and the patient woke up the next day to find that there were remnants of cat food on the counter, and he ate a cat food sandwich, and he was unaware of it, and found that his car, a few days later, found that the car that he parked the night before was parked a few blocks from his house, and apparently woke up in the middle of the night, drove, and had no recollection. So what I want to leave you with is the fact that patients who have restless leg syndrome, who are misdiagnosed as having insomnia, as they're essentially in getting treatment for the symptom of the restless leg syndrome as opposed to the insomnia, often develop what we call sleep-related eating disorder. That's very common in restless leg syndrome. Patients who are treated with hypnotic medications who then go on to develop very complex and unusual episodes at night, like sleepwalking, sleep driving, and sleep eating. And they're not eating fruits and vegetables. It's always unusual foods like, eating from a jar of mayonnaise or peanut butter, and it's just sometimes inedible items, so that's really important. So I'm just going to leave you with one slide, an ending slide, that a good night's sleep can have a tremendous impact on improving a patient's quality of life. And I want to make sure, if any of you have sleep difficulties, discuss this with your family physicians, discuss this with your primary care docs, and don't resort to poor sleep, because there is help, there are treatments, they're quite effective, and it's really nice to be able to talk to you about some of this and share some of my experience. So thanks for having me, and maybe I'll have 1 or 2 minutes for questions. Thank you for sharing that. So the question is about the teenager who is oversleeping and oversleeping for a few days out of a month. So the number one cause of prolonged sleep or excessive sleep in a teenager is a condition called delayed sleep phase syndrome, which is a circadian rhythm disorder where the teenager or the adolescent ends up sleeping very, very late, and they can't get up in the morning, or they have to wake up, and they're only getting 2 or 3 hours of sleep, and then they make up for that by oversleeping the next couple of days, making up for it. There is a very rare condition. It's called Klein-Levin syndrome. It's a very, very unusual syndrome in which patients also have periods of sleep for several days out of a month where they sleep for 20 hours each day. But it's extremely rare. They usually, it's not, you mentioned that he's not eating. In Klein-Levin syndrome, there is hyperphagia. They're eating a lot. And there is megaphagia, not only eating a lot, but eating large quantities of food. And there is a irritability, abnormal cognition, very, very rare, but I would probably suggest that you take your son to the pediatrician or the family physician and try to sort this out a little bit more carefully. 24, yeah. I see. Perhaps, yeah, thank you for sharing that. Yes. Absolutely. So the question is mentioning menopause or premenopausal symptoms as a trigger for insomnia. That is a really important issue, because patients who develop menopause and hot flashes that disrupt the sleep architecture can develop symptoms such as this 10 years after menopause. And luckily, there are some clinical trials looking at drugs like esapicolone, which is Lunesta, together with some low-dose antidepressants or anxiolytics showing good efficacy. Clonidine is often very effective to control the autonomic dysregulation in menopausal-related insomnia. But oftentimes, even if the menopausal symptoms go away, we can use medications and cognitive and behavioral therapy. I didn't mention CBT as a very effective homeopathic treatment, chai tea, which is together with relaxation techniques, improving the sleep hygiene, stimulus control, very effective, even more effective than medications themselves. The problem is patients don't have the time to do it. I see patients and they're looking for a pill. I tell them about CBT, and they say, well, we've already tried it. We read about it online at 2 a.m. You know, and I tell them, look, you have to devote time for it. It's like losing weight. You have to have a structured schedule. You have to have a person who will be your coach to learn how to sleep again. But thank you for bringing this up. Hormone therapy for menopausal insomnia hasn't been widely accepted, and the studies there are a lot of different data, and the data is somewhat confusing. So right now we don't have a consensus to use specific hormone replacement therapy to treat sleep problems in postmenopausal women with insomnia. One more question. Yes, in the back. Very good question. So certain medications, steroid pulse to treat autoimmune disease, multiple sclerosis, for example, the steroid does tend to worsen the insomnia. It's situational, so it's related to the medication. So we often want to prepare the patient, perhaps use specific agent to address the insomnia strategically. But certainly if this is a patient who is known to be, who is on a medication that has a temporal relationship to when the insomnia started, like certain antidepressants, venlafaxine in particular, that is known to worsen restless leg syndrome, the patient should discuss this with their physician to maybe try a different class or a different agent of antidepressants that may not affect restless leg syndrome. But I think a short strategic hypnotic medication specifically for the type of scenario that you're talking about of a steroidal pulse treatment may be effective together with cognitive and behavioral therapy. All right, thank you so much.